Hello, I'm Dr. Ahida Velazquez, Neuroanesthesiology Fellow at the University of Toronto. In this video, I'll guide you through the scalp lock technique, a simple yet effective procedure essential in the management of neurosurgical patients undergoing craniotomy. I'll also share some useful tips based on a research of the literature as well as my personal experience. For the setup, we're gonna need two 10cc syringes, 25 gauge needles, your choice of local anesthetics and concentrations, sterile gloves, prep stick with antiseptic solution, and gauze. Let's get into the scalp lock technique. Same as with any other block, begin with a brief timeout and prep the skin with antiseptic solution. Go from the forehead to the laterals of the head, as well anteriorly and posteriorly to the ear. Do the same with the other side. This technique involves 7 nerves on each side. I'll be using a total of 20 ml of local anesthetic. Although higher volumes has been described, it's always a good idea to calculate the toxic dose, especially if local skin infiltration is planned. For the anterior and frontal part of the scalp lock, start with the patient's head in a neutral position. First, locate the supraorbital notch 2.5 centimeters lateral to the midline. Use your non-injecting hand to palpate the superior border of the orbital rim. Keep your finger in place to control the block spread and to protect the eye. Insert the 25 gauge needle perpendicular to the bone, 1 centimeter above the notch. Aspirate and inject 1 ml of local anesthetic to block the supraorbital nerve. At the same injection site, flatten the needle and advance 1 centimeter towards the midline to reach the supratrochlear nerve. Again, aspirate and inject 1 ml of local anesthetic. As a recommendation, after each injection, gently massage the area for even distribution. Now, carefully turn the patient's head to the side to work on the lateral and temporal part of the scalp lock. Locate the zygomaticotemporal nerve in the area between the lateral border of the orbital rim and the upper part of the ear. As this nerve branches multiple times as it emerges through the temporalis fascia, both deep and subcutaneous injections are required. To start, palpate the orbital rim and create an imaginary line to the ear. Half along this line, or 1.5 centimeters behind the orbital rim, advance the needle at 90 degrees till bone is contact. Aspirate and begin with a deep injection of 1 ml of local anesthetic, followed by a superficial injection of 1 ml. Massage the area for better coverage. Move towards the ear and identify the tragus. The auriculotemporal nerve is located 1 centimeter anterior to the tragus, and it's posterior to the superficial temporal artery, above the level of the temporomandibular joint. Palpate the pulse and advance the needle posteriorly and superficially to reduce the risk of unintended facial nerve palsy, as motor branches are distributed deeper. After aspiration, inject 1 ml of local anesthetic. Gently massage the area. Locate the greater auricular nerve situated 1.5 centimeters behind the ear at the level of the tragus. Insert the needle perpendicular to the skin till bony contact is made. Aspirate and inject 1 ml of local anesthetic. Gently massage the area. Now, let's move to the posterior part of the scalp. Palpate the mastoid process and follow the inferior nuchal line to the occipital protuberance. Part the hair for better exposure and prep the skin with antiseptic solution. Divide the nuchal line into thirds. The lesser occipital nerve is found at the junction of the first and the second third. Here, advance the needle perpendicular to the skin. Aspirate and inject 2 ml of local anesthetic. Gently massage the area. Finally, the greater occipital nerve. Locate the greater occipital nerve between the second and the third thirds. An important landmark for this block is the occipital artery, as both may be found close in proximity to one another. If you can palpate the pulse of the occipital artery, insert the needle 1 centimeter medial to it. Aspirate and inject 2 ml of local anesthetic. Massage the area. As an additional technique that complements the scalp block, consider the superficial cervical plexus block, which is where the greater auricular and lesser occipital nerves originate. This plexus can be blocked using anatomic landmarks or ultrasound guidance. For the anatomic reference, draw a line between the mastoid process and the suprasternal notch. This area corresponds to the posterior border of the sternocleidomastoid muscle. Prep the skin with antiseptic solution. Along the middle third of the line, use a 25-gauge longer needle to inject 5 ml of local anesthetic subcutaneously. This plexus block can be used for different types of surgeries, including central lines, neck surgery, ACDF, and certain clavicle and upper shoulder procedures. And that's how we conclude the scalp lock technique. In conclusion, I hope this video was informative and helpful to master the scalp lock technique. As you think about this procedure, keep these 3 messages in mind. First, pain after craniotomy is common and under-recognized. Second, optimal analgesia after craniotomy is best achieved through a multimodal approach. And lastly, nerve blocks with local anesthesia are a valuable tool to provide patient care and achieve optimal neurosurgical outcomes. Thanks for watching.